Hi, Ramna.
Yeah, can I start? Can I start?
Yes, you can start.
Yeah. Good evening to all. I hope this day was good. Myself, Dr. Bhuneshwar Ramanan, FCP ID for a member, doing my ID pharmacist. I can I can start it again. Like we have to.
No problem. You can start it. If you want to start it,
Uh,
restart it.
uh,
Yeah.
yeah, ma'am. No, the background PPT is going. Is that okay,
Yeah.
ma'am?
So you have
Yeah.
any display of introduction or something?
No, ma'am. No, ma'am. No, ma'am.
Nothing.
Like yeah,
Okay.
I'm introducing you, ma'am, and I'm myself, ma'am.
So there
After
is
that,
no
we
slide
can
as such,
proceed.
right? There is no slide
No,
as
ma'am. No,
such.
ma'am. No. Yeah.
Okay.
No. 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 No.
You can proceed.
Yeah, I have a like icon in front of me. Okay, I'm going, ma'am. Ma'am.
Proceed.
Yeah, ma'am. Good evening to all. I hope this day was good. Myself, Dr. Bhuneshwar Ramanan, FCP ID for a member, doing my ID pharmacist fellowship in Royal Care Super Specialty Hospital, Coimbatore, Tamil Nadu. I'm very happy to welcome you all for this session. Today, we have a topic of formulary restriction and pre-authorization by Dr. Nishalla. Dr. Nishala is a formerly graduate from Sri Venkateswara College of Pharmacy, Hyderabad. She is currently working as a clinical pharmacist, coordinator, and medication safety officer. She has a 4.5 years experience of working in various specialties. She's been actively participating in antimicrobial stewardship at Continental Hospital, Hyderabad. And today's topic is formulary restriction, pre-authorization, and pharmacy-based intervention. Over to you, ma'am.
Hi, good evening all. This is Dr. Nischala. So today we are going to discuss about AMSP, formulary restrictions, pre-authorization, and pharmacy-based interventions. So the first So disclosure information, I do not have any relevant financial relationships with any commercial interests. Our learning objectives for today's presentation is about the antimicrobial stewardship strategies, formulary restriction, and pre-authorization. So the essential elements that are required for effective antimicrobial stewardship are having a good microbiology lab so that the reporting system is in proper condition, and then the organisms which are isolated are correctly reported. Based on that, the treatment would depend on. Next is the information technology. The IT is also required to every day to just compile the data of the consumption or to check on the microbiology data. For all of this, to have a ready information or also to track about the susceptibility and resistance pattern for the WHO WHONet data, and also to track if we are calculating DOT or DDD, we need to have information technologies in place. And then comprehensive multidisciplinary team approach. So if the antimicrobial stewardship does not involve one specific department as such, it involves a complete teamwork where it involves the microbiologist, ID physician, ID clinical pharmacist. There are various specialties where the antibiotics are used. So there are various specialties which should come into place along with the infection control nurse. And adding to that, monitoring of process and outcome measurement. So whatever the process that we do, whatever the outcomes that we attain, so that monitoring and the measures, the outcome measures should also be kept monitored throughout the process. So for now, we are going to discuss about the strategies that we have for the two things that we have discussed: prospective audit of antimicrobial use and formulary restriction pre-authorization. First, in prospective audit, this includes direct interaction and verbal or written feedback to the consultants, to the providers, whosoever is prescribing. Whether it can be like obtaining the complete information about the antimicrobials which are prescribed, and then taking the ID recommendations and giving back the recommendations to the prescribing consultant. This involves assessment of antimicrobial therapy by the antimicrobial stewardship team, having rounds as well. Ward rounds are also very important to assess the patient's clinical condition. Based on that, how many days an antibiotic should run, what type of treatment is going on. It is not always dependent on the cultures, that we always do not treat the lab parameters. We should also consider the patient's condition, whether the patient is in sepsis or septic shock. Based on that, how the treatment strategy should be changed. So the ward rounds becomes a major important thing. Next is monitoring of daily consumption by the EMR generated report. The other strategy is formulary restriction and pre-authorization. This involves a reduction in antimicrobial use and cost. Effectiveness of pre-authorization depends on authorizing individual. So if we keep pre-authorization, what do we understand by pre-authorization? As in, we will have to restrict few drugs. These antibiotics require pre-authorization before prescription. That means we are restricting few antibiotics, saying that the ID consultant involvement or a specified consultant involvement is mandatory, like to go forward to prescribe these kind of antibiotics. This for this we need to also involve pharmacy and therapeutics committee to come down on what kind of antibiotics, based on our restriction patterns, based on our organisms that we see, based on again WHO guidelines, we can do the restriction process. Next is role of formulary restriction in AMS. We are going to go in detail about this. So these are the core strategies for antimicrobial stewardship program. This optimize the use of antibiotics and reduce the development of antimicrobial resistance. The restrictive antibiotic formulary strategies, which involves first and foremost is maintaining the list of approved antibiotics, for which we need formulary restriction, that we have to restrict. And then to ensure these antibiotics are used appropriately based on the evidence, cost effectiveness, and local resistance patterns that we have in our institution. What is the purpose of this formulary restriction in an institution? This is to prevent the overuse and misuse of the antibiotics, to improve the patient outcomes by encouraging the selection of most appropriate antibiotic therapies based on the clinical condition of the patients. Next is having an institutional formulary. So what kind of, we have n number of antibiotics in our formulary, of which, based on a restriction process and the patients that we get, based on the clinical condition of the patients, what antibiotics do we need in the restriction formulary, that we'll have to first decide. And then this could result, institutional formulary restriction could result in substantial cost savings to the patient, also to the organization. But this could be ineffective in institutions where prescribers are able to circumvent. Any process will have pros and cons to it. So the formulary restriction, when we do, there can be chances of a con that we can discuss is prescribers are able to circumvent the restriction by ordering unapproved medications via a non-formulary pathway. And then institutional utilization criteria. One in this is setting up a restricted formulary, and then next is utilization criteria. As in, we'll have to mention for what indication this antibiotic is being specifically used. This can be done by developing a paper where indication is written by the consultant, and the ID consultant can just go through what are the indications, whether these indications are meeting the antimicrobial stewardship guidelines, or it can be a completely EMR system. So institutional utilization criteria, this indicate appropriate rationale for selection of a particular agent. This can be accomplished by EMR system or by order entry, requiring the prescriber to select the criteria in a pre-populated menu order in the entry screen. In institutions using, if there is no EMR setup and all, then we can do in a paper as well, by having a restricted antimicrobial form where a consultant prescribes an indication and then it is evaluated and a feedback is provided. So usually what are the antibiotics that we usually see for formulary restrictions are carbapenems. If we take carbapenems in meropenem, imipenem, cilastatin, we usually reserve these antibiotics for gram-negative resistant bacteria like multi-drug resistant Pseudomonas or Klebsiella species. In cephalosporins, there are newer cephalosporins which are coming into the market again. One example would be cefepime, which is a broad spectrum cephalosporin which covers various kinds of infection. So other like these kind of like newer generation antibiotics can also be under restriction criteria, so that these antibiotics are not misused. Vancomycin, we usually restrict it for MRSAs or life-threatening infections. Linezolid or daptomycin also for MRSA or VREs we restrict. Colistin, typically these are restricted for, these are treated as last resort. So these are restricted for multi-drug resistant gram-negative organisms, and this is in limited use because of the nephrotoxicity or neurotoxicity that the medication has. So this is a study that they've conducted like on the formulary restriction. So here in this study, what they have done is formulary restriction. This has proven an impact antimicrobial use in one intervention at University of Kentucky. They have conducted. In this, what they've done is the removal of ceftazidime and cefotaxime. They have put it under formulary restriction. Also, the restriction of ceftriaxone and carbapenem are also for approved indications. They have put an addition of like cefepime to the formulary, into the restriction formulary. The replacement of ciprofloxacin with levofloxacin on the formulary they have done, and 72-hour stop order directly as soon as vancomycin is prescribed. Immediately after 72 hours, there is an automatic stop order that they have done. So, what are the results that they have obtained? After like 16 follow-up analysis is what they've conducted, and they've evaluated antimicrobial use and resistant patterns in selected organisms. In 2000, the expenditures were decreased by $200,000 despite an increase in the inpatient days again, and there is further decline by 2002 by $600,000 as and when compared to 1998 expenditure is what they have concluded over here. Next is ceftazidime, cefotaxime, and ceftriaxone use was also decreased by 80% in 2002. Another benefit what they've observed from the study is decrease in resistant rates of several important pathogens, including multi-drug resistant Pseudomonas aeruginosa and MRSA rates. So what are the benefits of formulary restriction in an antimicrobial stewardship program? So first is reduction antimicrobial resistance. As we have told, the misuse of the antibiotics is reduced, thereby reduction in antimicrobial resistance. Next is preservation of antibiotic efficacy. If the antibiotics are not used left, right, and center for the appropriate indications when and where it is supposed to be used, the efficacy is preserved. Next is improved patient outcomes. So the appropriate antibiotic for a given time when it is used, the outcomes is also expected. And the main important thing is the cost saving for the institution, also to the patient, better surveillance and monitoring. So if there are like 100 patients on restricted antimicrobials of unnecessary indications, it becomes a very difficult thing. If everybody follows an antimicrobial stewardship very stringently, there will be only 70 to 80% of patients are on restricted antimicrobials, thereby reducing further by streamlining the antimicrobial stewardship program. That becomes easier to monitor the patients who actually require the restricted antimicrobials. We can have close monitoring. And coming to the challenges, every process will have again challenges. So what are the challenges over here? The clinician resistance. Whenever we say a surgeon or a clinician that this antibiotic is not supposed to be prescribed, this is under restriction criteria, or you need to specify an appropriate indication to use this kind of antibiotic. So there is always a resistance that comes up. This patient has some kind of clinical condition, or this patient required antibiotics, or patient might have been on previously treated with antibiotics, so that's the reason they wanted to use. There are multiple reasons which comes from various clinicians. So clinician resistance is the first and foremost thing whenever we do antimicrobial stewardship. And this formulary restriction could also increase the workload on the stewardship team. So we'll have to keep a check on whatever the restricted antimicrobials are, the usage of the antimicrobials, and giving prompt responses. If an ID consultant is involved into AMSP process, giving a prompt response from the ID consultant, the recommendations should be provided to the prescribing consultant. Balancing access and restriction. So what kind of antibiotics are accessible in what kind of conditions? If there are any like very sick patients, we cannot keep saying that this antibiotic is restricted in those set of patients. So how many hours it can be restricted, it can be used, and then the buffer period we should set up so that they can use in sicker patients so that the treatment is not delayed. So all of this process could also, if it is not done at the right time, it could also delay the treatment. So for that reason, we'll have to balance when it can be given an access or when it should be restricted. Resistant surveillance also should be conducted. Next is prior authorization based restriction. So, this approach is typically instituted in settings where we have a pre-existing restricted formulary. This method is perhaps the most effective but requires a trained person. Always a person should be involved because before even prescribing an antibiotic, we need an approval. So round the clock, we need to have a person who can give, who can communicate, who can do the approval process for it, like to avoid any kind of delays in any of the sicker patients. Integration of this process into workflow can be a little challenging if people are like the manpower is not available around the clock. Again, types of antibiotics which are typically subject to prior authorization are again broader spectrum antibiotics, carbapenems, cephalosporins, and fluoroquinolones. High risk antibiotics which have major kind of adverse drug reactions, like major kind of like side effects and all. So we'll have to restrict them. Mostly we restrict nephrotoxic antibiotics and all, like newer antibiotics which are coming into the market, like cefepime, metazobactam, or biopenems which are coming into the market. So we will keep a restriction so that it is not used left, right, and center. Antibiotics for non-evidence-based indication. Off-label indications also to be monitored very stringently. Next is how a prior authorization process will be followed. When the request is raised from a consultant side, the process has to be reviewed. That means why the prescriber has given a prescription to that patient, what is the condition, everything has to be evaluated, and immediate feedback and education has to be given on whether it is required or no, so that next would be the ongoing monitoring process. So for prior authorization, the benefits involved in it are reduction in the usage of inappropriate antibiotics, and then enhance the stewardship and clinical decision support, because every antibiotic before prescribing, we take a prior authorization. That will have more of appropriate prescriptions rather than waiting it until 48 hours of restriction or anything as such could delay the process as well. Here also we should consider again how prompt responses that we could give it. This could involve cost saving in it, and then patient safety outcomes. Next are the challenges. So challenges could be delay in treatment, as we have discussed. If there is no proper adequate manpower, or if there is no 24/7 ID consultant involved or an ID clinical pharmacist, that could delay the treatment process. So this could also increase the administrative burden, because everybody has to be there available round the clock, and the prompt response for all of this, the administrative burden will also increase. Risk of over-reliance on guidelines and equity and access issues. So for example, if there is any after hours availability of antimicrobials, if we restrict the timings, 9 to 6 only, we are going to restrict it. After 6, post 6, there are nobody who is going to available. This kind of process could also again leads to overriding the prescription patterns. Without pre-authorization, the prescribers may wait until the after hours, and then they will start prescribing the antimicrobials which are under formulary prior authorization, so that they can circumvent the process. So these could be a challenge. Another potential drawback to this process would be restriction of one agent may increase the consumption of another agent. Next, there's this study which was conducted, like the title would be Impact of Different Antimicrobial Stewardship Strategies for Reducing Antimicrobial Resistance and Antimicrobial Uses, a systematic literature review. So in the study, the impact of the study was, in the study, they have totally taken 35 papers, which includes a systematic review, of which 31% of studies use pre-authorization or formulary restriction, of which 64% trials interventions used this intervention independently or in combination. So 36% of trials of 64% have been conducted together with combined initiatives of education, training, and prospective audit and feedback. So what are the observations from the study? Although it has been observed in research that strict pre-authorizations are not feasible in many of the institutions, the monthly mean DDD by 100 bed days, when they've calculated, this had reduced from 96 plus or minus 7 days in a week to 65 plus or minus 6, as reported with pre-authorization intervention in the hospital. Next is the percentage of patients inoculated or infected with multi-drug resistant organisms have dropped from 36% to 13%. The admissions also have reduced to ICU, and time to discharge from ICU has also decreased from 48% to 29%. Short-term antimicrobial therapy reduced antibiotic exposure in seriously unwell ICU patients. And also this was also found that continuation of treatment for up to 15 hours was not able to produce any kind of significant clinical benefits. Next, the duration of hospital stays had also gradually reduced in short-term treatment groups by restricting antimicrobials. Next are the overall challenges in antimicrobial stewardship that we face on day-to-day when we take up antimicrobial stewardship program in a given institution are competition among the doctors, as in why somebody has to restrict me, why cannot I prescribe. So everybody has this kind of inhibitions, and absence of a champion, like having a champion in place who can keep a monitor, who can check all the antibiotics consumptions and give a prompt response, having a champion in hand. And then utility value of an antibiogram. Having an antibiogram for a hospital is very important to check on what are the susceptibility, resistance patterns for enforcement of regulations and time constraints. So if there's any delay, there are again, the whole process will get diluted. So there is like so much of information that has to be compiled, and so much of data work that has to be done. So there could be time constraints where we could neglect a few things. So that has to be managed properly. Lack of interdepartmental coordination. As we've already discussed, antimicrobial stewardship program itself involves like wide range of specialities involved. There should be interdepartmental coordination and minimal supporting facilities. If there's no proper microbiology, that antimicrobial stewardship program cannot be conducted adequately, or an IT, if it is not properly set up, or not having a champion, not having an organization support or various specialities support, to run an antimicrobial stewardship program becomes a very difficult. So these are the references. Thank you.
Yeah, it's a wonderful session, and it's really a very informative one. And every steward should know about these things. And I have some questions regarding this, ma'am. Can we go, ma'am?
Yes, yeah, we can go ahead.
Yeah, ma'am. Like previously you told, like we have reduced the cost by using the pre-authorization and formulary restriction. Like how can we do that, ma'am? Like if what I'm saying means when a hospital purchases a bulk amount of like a meropenem, they have a margin. So if the high sale of meropenem and high usage of meropenem, they have a, like a, what I'm saying, they have like profit. But in the time they will hear about you, we will use this, which means they have lost now. Like how will you manage dosing and what we have to do for that?
See, we to convince an organization to reduce the usage of antibiotics, that requires like whole a lot of story is people should be having that like urge to use the appropriate antibiotics. And every organization, if we take on commercial things, definitely they do not want to cut down on their market. The right way to convince the management or anybody is, see, it is not like one antibiotic if you are reducing or one antibiotic if you are increasing, that will increase the like commercial values for the management. We will have to say that wherever needed, if we use for those set of patients, the hospital number of hospital days will come down. Number of hospital days, if it comes down, that will give a positive impact on patients, thereby increasing the complete patient footfalls to the hospital.
Yeah, yeah, okay, ma'am. Got it, ma'am. Got it, ma'am. And I have another thing. Like when a hospital doesn't have a EMR, so
Mhm.
for that hospital, how they approaches a DDT and DOT, like metrics, like how they can go on. Is there any idea to go with that, ma'am? Like DOT, monitoring those things.
Yeah. So DOT, we can do it in a manual process as well. DOT as in
Okay.
like how many days the treatment duration is going on everyday basis. That will again increase the burden on the ID clinical pharmacist, but still we can keep doing that duration of treatment for each patient, because we track on everyday basis when we take the consumption, and when we track, we know where the patients are. So how many days it is going on, we keep monitoring. So every third day, every fifth day, we keep going and we keep checking on the patients for the clinical condition. That's how we will have a back-end report of duration of therapy. From that, we can calculate. For if you have to say DDD should have a tool which is not a paid
Yeah,
thing or anything. They can directly download and then they can use it.
yeah, yeah, ma'am. And another one, ma'am. Like some hospital have a different restricted antibiotics. Like in my hospital, we have all meropenems, like all carbapenems and those things. But some hospital they doesn't involve a meropenem, and
Mhm.
if they involve not involve meropenem also, they use carbapenem as a restricted. And some hospital uses clindamycin as a reserved drug,
Yeah.
but some hospital doesn't use it. Like how we can select those things? Like we have to choose according to our use, or like is there any guidelines, or we have to follow the aware, or like which
Yeah.
should be a correct thing, ma'am?
We have an aware classification. If we want a guideline specific, we have an aware classification that we can go ahead with. Otherwise, it always depends on our antibiograms, the local guidelines, the local restriction, like resistance patterns, and what kind of patients are we getting, what kind of antibiotic usage, what kind of burden of antibiotics are we having in our institution. Based on that, the restriction policies can set up.
Yeah, okay, ma'am. Okay, ma'am. Like and like how we can manage the competition between the doctors, ma'am. Like because they will choose, oh, why can I not use this? Because I'm
Definitely.
daily seeing those things.
Yes.
That's only I'm asking how we can, like, because they are doctors and we don't have a like guts to go and talk.
Yes.
If we talk means we will get fired.
Yeah, yeah.
Yeah.
The antimicrobial stewardship complete program is itself like people have to adjust. All the consultants need to adjust to that, to the process. It is not like one day process where every consultant has to listen to it. It is a slow process where we'll have to give the recommendations. We should wait for them to accept. We should provide few like evidence-based articles and evidence-based studies and present it to them. If we try and say with evidence, why not anybody will get convinced? If they have some evidence, we should be in a position to check those evidences, and then the discussion should come to a final conclusion that a patient should have an appropriate treatment. It is not that a win-win situation or win-lose situation. So a final, like we should reach a final point where the appropriate treatment is going to the patient.
Yeah, yeah, ma'am. I think this would be a very helpful. Thank you for this session, ma'am. It's really helpful thing, ma'am, and we very happy to have you in our side, ma'am. Thank
Thank
you,
you.
ma'am. We can wind up, ma'am.
Yeah,
Yeah,
thank you. Good evening,
yeah.
all. Thank you so much.
Thank you, ma'am.